Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative, NNHQCC. My name is Kate Crump with the New England QIN-QIO. This is the third webinar from our 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's webinar will focus on antimicrobial stewardship, strategies for implementation. Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded. The presentation, recording, and transcript will be posted to the event page. The phone lines will be on mute for the duration of the presentation. Feel free to use your phone's manual mute button as added precaution, but please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Sarah Dudley from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. We will also have time for questions at the end of the presentation, and we'll open the phone lines for questions at that time. Lastly, if you find that the presentation appears a little cut off, please use the plus or minus icons in the top right of the presentation window to fit to your screen. I will now mute the lines. An automated message will play. Speakers, please unmute yourself after the message by pressing #6.
The leader has muted your line. To unmute your line, press #6.
Okay, now to introduce our first speaker, I'm going to turn it over to Melissa Cummings from the Bureau of Infectious Disease and Laboratory Sciences and the Massachusetts Department of Public Health. Melissa?
Great, thank you so much. Good morning, everyone. On behalf of the Massachusetts Department of Public Health, I'd like to welcome you to today's presentation and to thank you for your commitment to quality improvement in infection control and antimicrobial stewardship. Our speakers today are a team from Tufts Medical Center. The first is Dr. Shira Doron. She is a physician in the Division of Infectious Diseases at Tufts Medical Center. She's been the physician head of the Antimicrobial Stewardship program there since 2005 and is also the Associate Hospital Epidemiologist. Also presenting is Dr. Shira Beaulac. She is the pharmacist head of the Antimicrobial Stewardship program at Tufts Medical Center, as well as the infectious diseases pharmacist for the institution. And third, we have Dr. Gabriela Andujar Vazquez, who is also a physician in the Division of Infectious Diseases at Tufts. She is also part of the Tufts Medical Center Antimicrobial Stewardship team and has a special interest in rapid diagnostics and stewardship in the outpatient setting. With that, I will turn the slides over to our presenters. Thank you.
All right, hi, good morning. It's Gabriela. I will be starting the lecture today. The objectives of this lecture are, as outlined in this slide, we're going to review the landscape of antimicrobial use and resistance in long-term care and regulatory requirements surrounding stewardship. We're going to define the elements for a successful stewardship program, outline the role of each member of the care team in carrying out the goals of stewardship, explore resources for policy and protocol development, and describe examples of stewardship interventions that have been successful at other long-term care facilities. So we're going to start with a polling question. How confident are you that the antimicrobial stewardship policy and practices in your facility are adequate to reduce unnecessary antibiotic use? A, I'm completely confident that the antimicrobial stewardship policy and practices in my facility are adequate. B, I'm somewhat confident that the antimicrobial stewardship policy and practices in my facility are adequate. Or C, I have no confidence that the antimicrobial stewardship policy and practices in my facility are adequate. So you have it at the right side of your screen. You can click which of your answers would it be, A, B, or C, and you can submit your question. All right, so while we wait for the answers, I'll move on to the next slide. So starting with the incidence or prevalence of antibiotic overuse and how prevalent it is in the long-term care facilities. This is a study showing the incidence of endemic infections in long-term care facilities, and this is extrapolating this to the population in the U.S. Here are the types of infections, and the bottom one is all these infections taken together. And basically this number ranging from 1.8 to 13.5 is showing you the incidence rate per 1,000 living care days, and then extrapolates that into millions of patients, or I guess cases, in the U.S. that they're assuming they are on antibiotics because they have some sort of type of infection, while in the acute long-term care facility or long-term care facility. So it shows you how antibiotic overuse can be very prevalent in the long-term care facilities. So it seems like from our polling questions, most of the people are in the middle. They're somewhat confident that the antimicrobial stewardship policy and practices in my facility are adequate. So not that bad. I mean, they're in the middle, so not completely confident or have no confidence, but somewhat in the middle, which is good. So just to have a little bit of epidemiology and how much is the burden of antibiotic overuse in the long-term care facilities, it is estimated that 50 to 75% of long-term care residents in the U.S. have at least one antibiotic prescription per year. And of these, 25 to 75% of all systemic antibiotic prescriptions and 60% of topical prescriptions are inappropriate or necessary in the long-term care facility. So it's a lot of burden of antibiotic overuse in the long-term care facility. So why is it that we're doing, I guess, so poorly, or what is it that may be affecting all this? So there's a couple of things that could be contributing to this. The first is workflow related. We know physicians have limited time to be taking care and evaluating each single patient in long-term care facilities. They don't have readily available references. They don't have, many of the long-term care facilities lack institutional prescribing guidelines. They don't have direct oversight, or expertise readily available to help guide the antibiotic therapy, and also, lack of special diagnostics and labs that will help be more confident whatever the diagnosis it is that you're trying to treat or treat with an antibiotic. And also culture-related. A lot of patients in the long-term care facilities are elderly and with multiple comorbidities. They're very frail, and you feel like if you miss something, they will very quickly get very sick if you don't start the broad-spectrum antibiotic very quickly. Or you have a family member that's very demanding and really wants their family member to be on an antibiotic for some reason. Or, there's fear that if you miss something, that there will be institutional litigation consequences. And talking about consequences, this is a study basically showing the factors that are associated with the acquisition of multi-drug resistant gram-negatives, and these are the variables that they looked into. And at the bottom, you see highlighted, there basically highlights that the only statistically significant factor associated with acquiring a multi-drug resistant gram-negative bacteria was interval antibiotic exposure with an odds ratio of 5.5. None of the other things they looked into was significant as this. So what can we do to try to overcome this barrier? So the CDC came up with the core elements of antibiotic stewardship for nursing homes, and they're mainly composed of 7 pillars, which is the first one being leadership commitment, basically someone in your institution that demonstrates, or I guess everyone in your institution that demonstrates that they're committed to trying to combat antibiotic resistant and antibiotic overuse. And accountability, someone identified in your institution, what we call champion, either physician, nursing, or someone for pharmacy that will promote antimicrobial stewardship concepts in the institution. Having access to drug expertise, whether it's a consultant pharmacist or an expert in training in antibiotic stewardship for your facility to help guide decisions based on their expertise. Action, basically implementing at least one policy, whether it's small or big, but at least one, and then tracking at least that policy, trying to measure the process and measure the outcome. And finally, reporting, providing feedback on antibiotic use to prescription clinicians, because if you don't provide them feedback, they don't know how they're doing, and educating them, which is the key, trying to get clinicians and staff involved and educated, but also families and patients that to know and be aware of the issues with antibiotic resistance and the opportunities to improve antibiotic use. So we have 5 ingredients for a successful program. Culture change, provider education, use of metrics and benchmarking, use of microbiology laboratory, mainly antibiograms, and use of technology and informatics. We're going to touch in this webinar we're going to talk about the first 2, and then the other 3 we're going to go more into depth in the next webinars in the future. So the first one, culture change, it's basically educating and trying to get clinicians, physicians to understand the issue, be aware of the problem. And also we know that a lot of physicians are very reluctant to lose their autonomy and have someone else trying to question maybe or dictate their decisions. So, we would, in order to get through that barrier, you need champions and teaching services, people that are create a multidisciplinary, everyone from different perspectives to try to create a culture change in the facility. And try to use concepts like behavior change theory and feedback. Feedback is very important, so you know what will be working and what would not be working in your institution, because each institution is particular to their needs. The second ingredient would be provider education. A lot of the doctors in medical school and even in nursing school and other healthcare providers, they don't have concept of stewardship in their training. So this is sort of a new concept that may be for them. They may not have been thinking of trying to really be more conscious of their antibiotic use and choice. And try to remind yourself that even the smallest interaction with any provider can be an education opportunity. Focus on trying to discern between colonization versus infection. Whether it's really a community-acquired infection versus a hospital-acquired one. When to de-escalate. The fact that the patient can transfer with his antibiotic doesn't mean that you just reflexively have to continue it. You can question, is it really necessary to keep it? Or is this the appropriate antibiotic that the patient came in? And try to every day think about each antibiotic, how long do we need to really continue it, and try to think about early discontinuation. So this is basically showing a study my colleagues here at Tufts did with 3 different they basically surveyed 3 different hospital providers, including house staff and attendings. And this graph is basically showing you here the proportion of healthcare practitioners with higher knowledge scores regarding carbapenem-resistant Enterobacteriaceae, and the percentages are the knowledge scores. And then this is showing you the years of experience, where there's less than 3 years out of training, between 5 and 10, more than 10. And this basically shows you that you're less likely to know what a carbapenem-resistant Enterobacteriaceae is as far as the more you are far away from your training completion. So if you're more than 10 years out of training, there's an odds ratio of 2.3 that you will most likely won't know what a carbapenem-resistant Enterobacteriaceae is, compared to house staff or attendings that are 3 years or less out of training. So showing you that education, provider education, and constant talking about all these issues and problems are important to combat antibiotic resistance. So now I'm going to pass you to my colleague, Shira, who will keep talking about what you can do in your facilities to combat. Yeah, so I want to empower really everyone on the call here. I know that based on our prior feedback, we have a lot of nursing representation, some pharmacist representation, and some clinician representation from each facility. So I want to empower each of you to do your part to help prevent antibiotic resistance and participate in these antibiotic stewardship programs. So I'm going to first start by focusing on what long-term care facility administrators can do, because these guys are at the top of the chain and really can direct everyone at the facility to really fall in line and get on board with the fact that resistance is coming, and we need to do something as a healthcare institution to combat that. So we encourage long-term care facility administrators to establish these multidisciplinary teams that address antibiotic stewardship and optimize drug use. Not only is that something that's strongly recommended from a lot of governing bodies, but it's now a requirement per CMS criteria. So this is something that the administrators really need to help coordinate. We also need to make sure that that multidisciplinary team does create some sort of protocols that are going to outline the appropriate circumstances around antibiotic use. Also, these administrators really should create some sort of an infrastructure to review the antibiotic culture data to identify whether there is a worsening resistance problem. So that can involve, trending changes in your antibiogram if you have one. Or if you just notice a cluster outbreak of a certain bad bug. Our administrators should also not only create these protocols about antibiotic use, but also create some sort of a protocol to make sure that if there is a culture sent, making sure that it is indeed checked and that the antibiotics are adjusted based on those culture results. Because there's really no utility in taking a culture if you're not really going to follow up on the results anyway. It's challenging with care that changes every day. One person covering this day, another person covering for the weekend. Sometimes some of these results can get lost in the shuffle, but making sure that 3 days later when these results come back, having some infrastructure to make sure that they get followed up on. And lastly, we encourage our administrators to create some sort of program that provides for a periodic review of antibiotic utilization, kind of from more of a 10,000-foot view, doing some sort of drug utilization analysis, seeing if there's any problem spots. Moving on to our long-term care facilities, nurses really are our champions here. Nurses are, for several years now, from Gallup polls, nurses are viewed as the most trusted profession of all of the professions, and are really need to be our voice of reason here and help encourage rational antibiotic use, because they're really the champions at the patient's bedside. We encourage our long-term care facilities to be familiar with some of these protocols around testing and treatment for our bacterial infections, so that way they can help intervene early for patients that do have true bacterial infections, and to help encourage holding off on antibiotics when it's appropriate for these protocols. Our nurses are really responsible for educating our patients and families because they're the ones, like I said, are at the bedside, and having our nurses empowered to educate about not using antibiotics for respiratory viral infections, and not inappropriately using antibiotics for a suspected UTI or asymptomatic bacteriuria. Those are things where we really need our nurses to kind of step up to the plate, and many nurses have really well demonstrated how effective they can be in limiting these. Also, we ask that the long-term care facilities help identify advanced directives for patients who don't really have antibiotics as part of their goals of care, and also help coordinate with transferring and referring facilities about pending lab results. As I mentioned, sometimes patients can get lost in the shuffle, and our nurses are often the bedside advocates that really help put all the pieces together. Moving on to our prescribers, because they're the ones that kind of have the power of the pen. So we encourage our prescribers to use some sort of screening tools or protocols, so that way it can help direct the use of antibiotics to optimizing appropriateness and prescribe judiciously. We also encourage our prescribers to educate each other, educate other clinicians, educate the patients and family members and other staff, and really try to involve themselves in some sort of peer review process, because as Gabriela mentioned, there really isn't much feedback once you're in practice, and providing feedback to each other is really useful for improving and standardizing prescribing practices. And lastly, we really need to work with the prescribers to implement some sort of measures that can help reduce the need for even using antibiotics. So avoid the use of an indwelling urinary catheter, which can then prevent a urinary tract infection. Immunize patients whenever possible, so that way they don't develop those bacterial infections. Decubitus ulcer prevention to prevent skin breakdown and therefore wound infections, things like that. And then lastly, our long-term care facility pharmacists are really important as kind of the back-end expertise to help put a stewardship program together. So not only is it recommended, but it's also required that our pharmacists review antibiotic utilization and provide feedback about appropriateness and identify opportunities for prescribing to bring up at QI meetings. Also, our pharmacists can educate physicians and nurses about appropriate antibiotic use, how to narrow the spectrum of antibiotics based on cultures. They are expected to be involved in preparing these antibiotic use protocols that are dictated per the mega rule. And also, we encourage our pharmacists to use their pharmacist training and apply pharmacokinetic principles to antibiotic use. One example here is for the facilities that do provide IV medications to help dose pharmacokinetically complex drugs like vancomycin, or maybe spacing out divalent cations from drugs that can chelate with them, like fluoroquinolones or tetracyclines. We also hope that our pharmacists can help make sure that the drugs that a patient receives are compatible with their allergy history, and always strongly encourage the use of oral drugs whenever possible, rather than having patients unnecessarily on IV therapy. So lastly, I've kind of mentioned what each specific role can do, but we need to work together. So as a facility, the expectation is that you're able to develop communication tools that are going to share critical pieces of information at the time of transfer, and those could be culture results from their prior history, or some pending results that you've sent off prior to transfer, what the patient's been treated on in the past, if they require any precautions, including if they have a history of C. diff, and any immunizations they have or may need. Also, it can help improve the use of antibiotics if we ensure that the contact information is provided for follow-up, as well as any pending results, and create these cross-facility teams that are going to help address some of these antibiotic stewardship and infection prevention issues. So I've listed, I've mentioned a lot of things that each role can do, and some things that we can do together. Given your role, each of your roles here on the call today, which would you rank as the largest barrier to implementation of a successful stewardship program at your facility? Would it be provider attitude, provider training, or potentially, not having our providers that aren't trained as well in stewardship or appropriate antibiotic use, demanding patients and family, access to technology and diagnostics, access to clinical expertise, and specifically ID consultants, having dedicated time for your stewardship program, or something else? So the poll is open, and we look forward to hearing what you foresee as the biggest barriers, not only because that can help us, tailor these materials to you, but we're curious to hear, boots on the ground, what are you seeing and what battles are you facing? So the poll is just about closing, and as the results, this is a 45-second poll, so it's still open. Get in your answers for the next few seconds. And as the answers are tabulating, I'm going to move into the next section, which is, it's been nice me telling you all these great things that you should be doing, but we recognize you have a lot of things on your plate. So I wanted to give some tangible examples of what you can do to turn some of this great theory into action. I'm going to incorporate some of the requirements from the CMS regulations, as well as some best practices from the CDC. In terms of barriers that most people are facing, we see patient and family demands, as well as having dedicated time as the two largest barriers that people are facing. Having adequate training for providers or their attitude kind of comes in second place. So all of those are things that we will make sure we focus on in future webinars. So as I mentioned, there are some new requirements that you need to have in terms of antibiotic stewardship. One of them is that you need to have a policy that dictates your antibiotic stewardship committee. That you need to have an antibiotic stewardship committee that for your facilities that is going to include either your medical director, or the medical director can designate another clinician to be the stewardship physician. You should have involvement with your infection preventionist, and your consultant pharmacist should be a part of this committee. Those are the three required members. There are some other recommended members that you can include, like the director or assistant director of nursing, including some frontline staff who can give you some real-world perspective as you're creating these policies and procedures. It's also recommended to have some administrative staff, either a board member or maybe a designee from a board member. And lastly, a representative from the Resident Patient Family Council. And that's one that I especially think is really useful to have, as we have so many people mentioning that the patient and family demands are the biggest barriers to having a successful stewardship program. Maybe being able to hear from them directly and being able to educate them directly would be a useful tool in improving antibiotic use. So this is the makeup of your antibiotic stewardship committee, and that committee is responsible for managing at least two policies. One of them is the antibiotic stewardship policy, which is going to outline how you have dedicated time to carry out these stewardship activities, and it is mandated that there is dedicated time separate from infection control responsibilities. And with that dedicated time, what's going to happen? Who's doing what? So there needs to be a very clear outline of what's the responsibility of the consultant pharmacist, which is going to include assessing, monitoring, and communicating about antibiotic use, as well as what are the expectations of the medical director or their designated clinician in terms of accountability, policy development, and being that educational resource. Within this required policy, you need to outline what is your infrastructure, what is the system that you're going to have for antibiotic use, whether it's routinely reviewing patient records or using some sort of data tool, electronic tool, whatever it may be, it just needs to be outlined in this policy. And both this and any drug use policies need to be reviewed at least annually. So as I've mentioned, the Stewardship Committee is responsible for at least two policies, one of them being this policy and one of them being drug use policies. So as I mentioned, the antibiotic stewardship policy or the antibiotic committee has to maintain those antibiotic use protocols and develop and maintain that system for antibiotic use. It's also falling on the antibiotic subcommittee to be responsible for the antibiogram, to coordinate education on antibiotic stewardship, and it's expected that the Antibiotic Stewardship Committee meets at least quarterly. It's been described that many stewardship committees are just kind of tacking this on to their quarterly coffee meeting. There are some very clear responsibilities for the medical director, as I mentioned previously, but they really need to serve as the primary medical point of contact for the committee, really spearhead the development of these antibiotic use guidelines, play an active role in these educational activities, and provide individualized feedback to other prescribers, because many prescribers don't realize that they're over-prescribing. And the consultant pharmacists, although they're not technically on staff, they really need to play a huge role in these committees, reviewing the antibiotics during their medication reviews, and really assessing appropriateness or assisting in the assessment of appropriateness, and help to make those policies and procedures and make recommendations to the stewardship committee. So as I mentioned, the other piece of this policy development is having these antibiotic use protocols. They need to be reviewed at least annually, and there's no specific guidance in exactly what they need to be. They can be focused on clinical conditions, saying, you're going to have a guideline for the treatment of upper respiratory tract infection and a treatment of urinary tract infection. They can focus on durations of therapy, so what you as a facility are going to do about patients who are on antibiotics for greater than 1 week or greater than 2 weeks. Or your policies could focus around certain drugs and how you want to handle patients that are on certain high-risk medications or broad-spectrum medications. And within these policies, they should provide some sort of guidance, not only on the treatment choices, but as well as diagnostics that lead you to those antibiotic treatments, and should provide guidance on the appropriateness of duration of therapy. So moving on to the kind of tangible things that you can do as improving antibiotic use, one thing that's really easy that can be done, we consider it low-hanging fruit because, it's a simple thing to do, is for patients who are on antibiotics and really any drugs that have good oral bioavailability, we get them off the IV product and onto the oral one. So here I have listed some common ones like, your fluoroquinolones, linezolid, Flagyl, but also things like H2 blockers and PPIs and, a lot of your antihypertensives. Whenever something can be given orally, it should be given orally. It decreases length of stay, decreases cost of care, it decreases your risk for having a Lyme-related infection. It also is associated with much more patient satisfaction. Patients don't want to have an IV if they don't have to. Also, working with your consultant pharmacist, really use pharmacokinetic and pharmacodynamic principles to optimize patient doses that are going to incorporate a patient's age, renal function, or weight to make sure that they're on the right dose. Make sure they're on antibiotics that are really focused on the causative organism as opposed to empiric therapy that just got started and keeps on rolling. Making sure that the drugs that you're using are actually going to get to the presumed site of infection. We try to use drugs that concentrate in the urine for urinary tract infections. For pneumonia and for the CNS infections, we try to make sure that we have antibiotics that are going to get to that site. And working with your consultant pharmacist can really help making sure that you're capitalizing on that. And lastly, for patients that do require IV antibiotics, specifically penicillin and beta-lactam-based antibiotics, giving them over extended infusions or running them just over a longer period of time can help them work better. So these are all some kind of low-hanging fruit that you can do, simple, small interventions that you can take easily. But then I'm going to turn it over to Shira, who's going to talk about some more intensive but feasible interventions to improve these. Great. So I have a few examples to share with you of programs that were implemented in long-term care that were successful. And there are three very differently approached programs. I think they will illustrate for you some of the potential options for implementation. So the first one was published in the prestigious Journal of Antimicrobial Chemotherapy, and it's a study that was conducted in the UK. So this is the National Health Service, obviously, different in terms of resources from what we have available. But the study was on the effect of implementation of a novel antimicrobial stewardship tool on antibiotic use in nursing homes, and it was a prospective plus or randomized control pilot study. And they called the program the Resident Antimicrobial Management Plan, RAMP, and there were 30 nursing homes with between them with 1,832 beds. The tool had two parts, the initiation of treatment part and the review of treatment part. And during the 12-week intervention, 1,628 residents were given antibiotics pre-intervention and 1,610 post-intervention. So the first part of the tool was designed to make sure good practice points were used at initiation of antibiotics. And I think any facility should do something like this. So those good practice points are that clinical signs and symptoms of infection have to be present in order for the patient to qualify for antibiotics. We're going to talk a lot about that in later webinars. The second is that the resident must be examined by a physician, that a diagnosis and site of infection must be documented. So antibiotics in general, for example, should not be prescribed for fever. One has to assess the patient and come up with at least a suspected diagnosis and site. Clinical specimens should be sent. The antibiotic should be appropriate for the indication, the allergies, and the patient's comorbidities. And then that the antibiotic should be initiated promptly. All of those things are checked off at the initiation of antibiotics. The second part of the tool happens at 48 to 72 hours after initiation of antibiotics. And so there is a documented review at that time. At that point, the provider documents whether there's a stop date or a planned review date, whether the resident is re-examined by the physician, the results of the cultures are noted, and the outcome of treatment is assessed. Is the patient getting better on the current antibiotic? All of those really, really important that those happen at 48 to 72 hours. And so these are the results. Remember, this is over a 12-week period, so there's not a lot of potential for giant changes here. But what we did see is statistically significant decreases between the pre-intervention and the post-intervention periods in the amount of antibiotic used, and that was quantified by defined daily doses per 1,000 patient days, which is an international standard for quantifying antibiotic use. And you can see that in the control group, there was actually a significant increase there was no intervention happening, but over the same time period, there was a significant increase in antibiotic use. This study was done in the United States, specifically in a VA nursing home, the Cleveland VA to be exact. And this was, again, a prestigious journal, Infection Control and Hospital Epidemiology, and a very experienced stewardship team of heavy hitters from Cleveland. And the study was on the effective antimicrobial stewardship in a long-term care facility using an infectious disease consultation service, which they called the LID service, Long-Term Care Infectious Disease Service. And what they did was a small team of providers, an ID physician with a nurse practitioner, provided ID services for a 4-ward, 160-bed long-term care facility. And I see a question in the chat box on resources or time that is necessary to dedicate to stewardship, and I think this gets at that question to some extent. The ID physician and nurse practitioner saw patients or residents in the nursing home only once a week, but they were available for remote consultation the rest of the week using the electronic medical record, so accessing it from wherever they were, and telephone calls. That service saw an average of 7 patients during that one day a week and fielded only 5 to 10 phone calls every week. So over a 7-day week or even a 5-day week, that's not a lot of time. And they actually found that nearly 1/3 of the consults that they did required only one visit. The remaining patients required an average of 3 to 6 visits, ranging from 2 to 20 visits. And here's what they found. This is a complicated figure, but the top here represents the nursing home. The bottom is the hospital affiliated with the nursing home, where no intervention was done. And the hospital is serving as the control group here. Now the black filled-in shapes represent the pre-intervention, so before the lid service was implemented for both the long-term care facility and the hospital. And so you can see and then the top line is total antibiotic use, followed by oral antibiotics, followed by IV antibiotics in both cases. And so what you can see is, particularly in the hospital, you can see a very flat-ish line for antibiotic use during the pre-intervention period, and after the intervention, which didn't happen in the acute care hospital, the antibiotic usage stays pretty flat for all categories. Whereas in the nursing home, you had a little bit of an increase over time in IV antibiotics, a little bit of a decreasing slope for total antibiotic use. But once the intervention was implemented, you see more sloped downward curves here representing antibiotics. What you can very clearly see visually is that you have decreasing trends in antibiotic usage in all three categories compared to the directions that they were going pre-intervention. You also see some interesting things happening here with Clostridium difficile. Now, in this curve, this represents the filled-in shapes represent pre-intervention, and the open shapes represent post-intervention. And the top lines represent the acute care hospital, and the bottom lines represent the long-term care facility. And so what you can see is pre-intervention, both the acute care hospitals and the long-term care facilities had increasing C. diff rates over a period from October 2007 to April 2009. But once the lid service was implemented, what you can see is that the hospital, where there was no intervention, continued to have very rapidly increasing rates of Clostridium difficile infection, whereas the nursing home started to see a downward slope. And the third example is one of ours. So this was a successful stewardship program that Shira and I and some other members of our team implemented at a long-term acute care hospital in Massachusetts, New England Sinai Hospital. And we were approached by facility leadership, and we were recruited to implement stewardship at their facility because of their commitment to quality patient care, particularly surrounding the treatment of infection and antibiotic usage. And they had an ID consultant who saw patients there several days a week. But that consultant did not have the time or the interest or the inclination to do stewardship, and that's why they decided to get us involved as outside consultants. So we worked with leadership. The ID consultant was present for the first meeting or two, and then sort of stepped away from the process. The infection preventionist was there, and the pharmacy director. And we came up with a plan. They were already doing end dates and indications as a requirement by pharmacy for all antimicrobials. So any order that came down to pharmacy without those two things was rejected. So the next thing we did is we came up with what we called the Great 8. What were the 8 antimicrobials? We thought that was a good number to start with. That had the biggest impact in terms of cost, in terms of frequency of unnecessary use, in terms of the ability to promote resistance. And we put that into a report. Our team consisted of an ID physician or two and an ID pharmacist, and we were off-site. We sometimes came by the hospital to do educational activities and grand rounds and stuff like that. But for the most part, we were off-site, and we reviewed data Monday through Friday. And what that consisted of was we used the electronic medical record, and we were lucky that the hospital did have a fully accessible electronic medical record. We logged on. We generated a report of patients on antimicrobials for at least 7 days, on the Great 8 antimicrobials. and we looked at those patients' medical records. We made all of our recommendations by email, actually. We sent an email to the infection preventionist, and she disseminated the recommendations to the appropriate providers. In the context of doing that, we came up with ideas for clinical pathways that we felt were needed, and we developed those together with the clinicians at the facility so that we could standardize care. We conducted a program from April 2011 through March of 2014, and in that time period, we made 885 recommendations on 734 patients. And again, this gets at the question that was asked about timing and resources. We've spent approximately 1 to 2 hours per week reviewing cases and providing our recommendations remotely. And I think you'll all agree that is not a lot of time commitment to conduct an antimicrobial stewardship program. Certainly at the beginning, in development of the program, we spent more than 1 to 2 hours per week, but once it was up and running, that was the entire obligation, and we're talking about a 150-bed facility. The residents had a mean age of 68 years with a mean length of stay of 50-60. This is a long-term acute care facility, as I mentioned. And just to give you a sense, the types of infections, actually the most common infection that we made recommendations on was colitis, with seeds plucked into the epithelium. The second most common, as you might expect, urinary tract infection. And our recommendations were as follows. We agreed with the management of the patient in 45% of the cases. So in the 55% in which we did not agree, we did an analysis, and about half were followed, our recommendations were followed within the first 72 hours. And that's over the entire time period. Now, our recommendations consisted of a number of different things, and you can see here that the most common recommendation was stop antibiotics now. But the second most common was actually we need more information with which to make a determination about the appropriateness of this antibiotic. So the chart doesn't reflect, for example, why the patient was started on an antibiotic, so we need more. Does the patient have symptoms was often a question. And in 10% of the cases, we actually thought the patient needed to be seen by an infectious disease specialist. And the other recommendations were as you see there. But I mentioned that half of our recommendations were followed within 72 hours. But over time, that number changed. And so as people became more and more accustomed to our interventions and our presence, and became trusted us more and more, we gained their trust. You can see that recommendation acceptance improved, so that by the end, there were months in which 100% of our recommendations were accepted within 72 hours. And as I showed you before, with the Cleveland program, we did get to enjoy the fruits of our labor. Here is the C. diff rate at the hospital, which was pretty flat pre-intervention, and then actually saw an immediate drop with our intervention, and a lot of that was, some of the low-hanging fruit that we described. There were some really bad practices that we got on top of right away, and then a downward slope throughout the rest of our involvement with that facility. And here are the antibiotic usage stats. So antibiotic usage total was going up. So were things like C. diff and MRSA antibiotics. And you can see that at the time of the intervention, there's an immediate drop and then a slope downward. And you can see similar, although less striking results here if you break it out by anti-pseudomonal, anti-MRSA, and anti-C. diff antibiotics. And we were happy that at the end of that time period, the reason that we stopped working with New England Sinai was actually that they realized that the investment was so fruitful, and that in fact they were seeing such a return on that investment in terms of resistant C. diff and antibiotic usage, that it made sense for them to bring those resources in-house. In other words, that it made sense for them to dedicate on-site FTEs to antimicrobial stewardship. And I think that time and time again, that has been proven in studies, whether in acute care or long-term care. So the general themes that we've covered today, that antimicrobial stewardship, it does require resources, and that you could consider contracting for help from outside experts if needed, and that you will be surprised that it may not take as many hours as you think. We were charging New England Sinai by the hour, and they were pretty happy with paying us for 1 to 2 hours per week. The cost of the additional resource input is consistently offset by the cost savings of using less antibiotics with additional benefits, lowering the rate of C. diff, resistance mitigation, improving patient safety, and small interventions can have a big effort. So don't be afraid to start. It may seem like what we're asking you to do here is insurmountable, but if you take one step at a time, if you get started with a small test of change and then a small intervention, what you will find is that you can reach your goal. So we're going to open up the lines for questions, and while that's being done, we're going to turn it over to QIN-QIO to go over some of the future plans and some of the housekeeping items for the group.
We're going to open the line for questions first. To unmute your line to ask a question, please use #6 or #6 on your phone, and the line will open for you to join us. While we wait for folks to join us on the line, let's check in with Sarah for any questions in chat.
So I have a few questions in chat for you. The first comes from Gail, right? Is there an example policy that can be shared for implementation?
I don't have an example policy, but the idea was because each facility is going to have their own policy, I can try to work in future webinars a little bit more guidance around what that's supposed to look like.
Excellent, thank you. And we have another question from Ruth. What is the suggested time amount to set aside for antibiotic stewardship?
Yeah, and I think that's what we were trying to address a little bit, and again, it's going to be different depending on the size of your facility, but it certainly is going to be an initial time commitment to set up the program. But what we have found is that the week-to-week, day-to-day requirement is not that onerous, and often you can overcome that, that issue of lack of time by bringing in an outside consultant.
Great. Any questions from the phone lines?
I see one question from the chat box about which regulations. I was mainly referring to the CMS mega rule because that's the major payer for most of the long-term care facilities on the line here. There's also some long-term care facilities are going to be accredited by the Joint Commission, but I think that's minority, and they have similar but mirroring requirements, and admittedly the Joint Commission requirements are a little bit more onerous than the mega rule requirements.
We have a couple more questions from chat, and Taro asked if the tool from the study is available to share with them.
Oh yeah, that's a good idea. We could do that. I believe it's an appendix within that published study, so we could definitely share that with the group in the follow-up email. That would be fine. I also wonder if Melissa or if QIN-QIO, I think example policies are probably a good idea, and I wonder if we could reach out to the group and see if people are willing to share their policies. We could pick out some of and maybe if people are willing, we could share that.
In the follow-up email and then collect them, share them with you to review, and go from there.
Yeah. I also see a question in chat about MRSA isolation. The next webinar is infection control prevention, and I think we'll probably talk a lot more about isolation precautions there. It is a tricky question because every facility in the world does isolation in a different way. But this particular question was sensitive to oxacillin, so that would be non-immersive methicillin sensitive stuff, or yes, so those patients in general would not require isolation precautions. There's a question about intervention. That word is pretty vague, you're right. And so when in the context of the studies that we described, we meant sort of the implementation of the full program. The interventions specifically, though, in each of those studies were different. So in the UK study, it was the intervention was simply that RAMP tool, that two-part tool. In the case of the Cleveland study, the intervention itself was simply the involvement of an ID physician with nurse practitioner with once weekly rounding or consulting on infected patients and taking curbside questions by phone. And in the case of our study in Massachusetts, the intervention was us reviewing medical records of patients on antibiotics. So really different, three completely different approaches to stewardship, all valid, all effective. Education or programs available to doctors or specialists. I would say that the PowerPoints and the recordings of this webinar series and our last webinar series are probably your best resource to provide to doctors and specialists that have not enrolled in this program because this is not on their radar screen, which is understandable. We could think about some concise versions of PowerPoint presentations that might be targeted just to physicians. I mean, we certainly have them in our own archive, and it might not be a bad idea to put together, I'm just reading between the lines with your question here, if you're looking for something concise, that's something like 30 to 40 slides, that would be a one-time deal for doctors and specialists. That's a good idea and something we could work on.
There's another question on how do we approach recommendations for urine samples to rule out UTI-related behaviors with our antibiotic stewardship.
We have a whole webinar on that coming up. So I don't have a clean and concise answer, but I will say that behavior is not necessarily a UTI, a change in behavior, and we have a lot to talk about that on May 8th.
It's probably almost never related to UTI, so it really requires a major mind shift. And it does involve getting your psychiatrist educated, which I know is not easy.
And the question about how to use an antibiogram, we have another whole webinar dedicated to that on September 11th. Oh, yeah. Yeah, in terms of monitoring and tracking your data, we're going to talk about how to use the antibiogram as part of that.
Right. Evidence-based. Donna asked about evidence-based de-escalation criteria for antibiotics for primary care. Yeah. I think we'll certainly get into that on the July 10th webinar, which will focus on selection, de-escalation, and duration. I think there are sort of two key pieces there. One is utilizing that culture result. So once you have the culture, the patient is then be on the narrowest spectrum agent possible to cover that organism. And then the other is to understand what the appropriate durations are for certain conditions. And we have guidelines for most infectious diseases that tell us what the appropriate durations are, and yet we know that most patients are treated for an excessively long period of time. So we'll go over all of that in the July webinar. Jessica asked about what do you do about the fact that you send a patient to the ED, let's say they slipped on a banana peel and they need an elbow x-ray, and they come back with a diagnosis of UTI. I mean, you didn't send them for a UTI. You don't think they have a UTI. They don't have symptoms of UTI, and they come back. And we hear that all the time. And that's why we had a whole slide today about on developing, strengthening those relationships between facilities, developing inter-facility transfer guidelines. And if you're the expert in stewardship, then and that's what we're seeing, is that the nursing homes are educating themselves on what this stuff is, and the EDs maybe not. And you need to have faith in your own clinical acumen there and stop the antibiotic, because that's the right thing to do for the patient.
So we're getting close to the end. If we missed any questions in chat, we will address them and include the responses in the follow-up email. I'm going to turn it over to Kate for some final announcements. And for folks from Massachusetts, if you could stay on the line after Kate's done with announcements, Melissa from the Mass Department of Public Health will be making a few additional announcements for folks in Massachusetts.
Thank you all for the great questions. We appreciate your time and hope you found this information helpful. I'm going to highlight some additional resources we have available, and when you close out of this webinar, an evaluation will automatically pop up on your computer. If you could please fill that out, we'd greatly appreciate it. As for resources, don't forget to mark your calendars for the remaining webinars for this series. As you can see on this slide here, webinars take place monthly through September. Check our website for more information or contact your state lead for help registering. Contacts are listed at the end of this presentation. And of course, don't forget to follow us on social media to get important alerts, news, and more. We also want to remind everyone that we have a free virtual learning system, the Learning Center, at learningforquality.org, number 4. This tool provides education in bite-sized chunks to accommodate busy schedules. Many courses have continuing education credits. Course topics include QATI, infection prevention training, mobility, antibiotic stewardship, CDI prevention, team steps, LTC communication module, pain management, reducing antipsychotic drug use, medication reconciliation, and much more. If you have questions, please send an email to learning@healthcentricadvisors.org for assistance. As always, your state nursing home team is available as a free source for you as participants of the New England Nursing Home Quality Care Collaborative. For support on your quality improvements initiatives, contact information for your state lead is listed here on the screen. This concludes the general session. Massachusetts participants, please stay on the line for an important update from the Massachusetts Department of Public Health. Other state participants, thank you all for joining us for today's webinar and have a great day.
The ball's back over to you, Melissa.
All right, great. Thanks so much. So for Massachusetts facilities, I know it's getting late. I'll just take a minute more of your time. Thank you again for your commitment to the program. Just a couple of quick reminders. We just wanted to remind all facilities that in order to receive recognition from the Health Department for full program completion and commitment, you do need to submit monthly antibiotic start data and participate in all webinars. If for any reason you missed one of the earlier webinars and you're joining the program late, that's okay. We have links posted. They're here. They're also on the QIN-QIO website. You can access those previous webinars. You can view them, and we can see that you have viewed them. So you will get credit for viewing and attending. And I just wanted to make a couple of notes with regard to submitting antibiotic start data. We received data from many, many facilities for the month of January. Thank you so much for that. There were some questions about calculating the number of resident days, and we had to follow up with a few facilities. So I just wanted to clarify, when we talk about resident days, what we need for you to do is add up the daily census for every day in the month to get the resident days for the month. We're not looking for an average daily census. We're looking for the total number of resident days for the month. So just wanted to make that clarification. And just another quick clarification regarding calculating percent occupancy. In order to do that, you would need to divide the number of beds occupied by the total number of beds and multiply by 100. And that will give you your percent occupancy if you're one of the facilities that is unable to provide the resident days. And then lastly, I just wanted to mention that we are in the process of assembling a virtual infection control and antibiotic stewardship toolkit, which will include many of the resources that have been discussed in all of these webinars. And also a reminder that your monthly antibiotic start data can occur beginning on the first day of each month for the prior month. So for example, for January, we were accepting data through the end of February for the month of January, and for those facilities that submitted January data, we have generated reports for you, and they will be sent to you by email within the next 1 to 2 days, so you can look for those. It's also time now to start submitting February data. You have until the last day of this month to submit your February data, and then we will begin issuing the February reports, and we'll continue on that track. So any questions, don't hesitate to reach out. My contact information is there, and I would just like to thank you all again for your time and your commitment to the program.
Thank you so much. We have one question. Could you repeat how to calculate the census per days again? Also, does that include bed hold?
Sure. I don't think we're counting bed holds. I think we're counting an actual resident present in a bed. So your daily census, so that would be residents present in the building for each day for the month. So let's say, just for the sake of explanation, you had 100 residents present for every day in the month of January. You would multiply 100 by 31 because there are 31 days in the month, and that would give you your total resident days. Now we know each day your census is probably a little bit different, so you are going to have to add up each day.
And this is Shira. I'll add that we should not be including bed holds.
Thank you.
There's no additional questions, so today's webinar has officially concluded. Thank you all. Have a great day.
Thank you. Bye-bye.
The leader has disconnected. The conference